Hi, my name is Elizabeth Velong, and I'd like to talk about the evolution of emergency medical protocols in EMS. So first, let's start with the basics. Tourniquets. Dating back to ancient civilizations, people used a strap of cloth or leather to make a makeshift tourniquet to apply to bleeding limbs. In 1718, the French surgeon Jean-Louis Petit invented an operating tourniquet to control the amount of pressure applied by either slowly adding or removing pressure, and this helped with reassessment during surgeries. And then in World War I and II, field medics would add tourniquets. However, during these wars, there was a stigma that was created around tourniquets, and that meant that you'd lose your limb if you have a tourniquet applied to you. Why is that? Because of extended application time till you see a surgeon. And also, they were added in certain situations that weren't necessarily needed, and direct pressure and elevating the wound could have been an easier solution while keeping your limb. So because of this added a bad taste in people's mouth about tourniquets, so they weren't used much in the Korean or Vietnam War. So the perspective on tourniquets began to change back after Frank Butler, a retired Navy captain, SEAL, and physician, wrote a book and introduced tactical combat casualty care in the 1990s. Butler's writings opened up the conversation regarding tourniquets for military and civilian use. And when issues arise in Afghanistan and Iraq, the military actually trained every soldier across the board some basic emergency medical care, including tourniquet trainings. And with this proper training, this created a better stigma around tourniquets and encouraged civilian use with tourniquets in EMS. So the initial adoption of tourniquets by hospital emergency medical services began in 2008, which rapidly expanded over the following years. Today, tourniquet training encompasses not only military, hospital, and first responder personnel, but also various professions worldwide. Next, let's talk about spine boards. Spine boards. American Academy of Orthopedic Surgeons published one of the first ENT textbooks in 1971. In this book, they proposed the use of a C-collar and a long spine board for patients with suspected spinal injuries. During my research, I was surprised to learn that this protocol was not credited by research and science, but rather by consensus of providers' opinions and individual experiences. No evidence at the time supported or refuted this practice, and long spine boards used to be made of wood. However, over time, hygiene and risk of infection came into conversation due to the difficulty cleaning blood and bodily fluids out of wood, and spine boards began being manufactured with plastic. In the 80s, people began questioning the use of spine boards because of the risks of respiratory compromise, tissue breakdown, and ineffective immobilization. And then more research showed the correlation of spine board use to higher pain scores, more radiographic testing, and higher hospital admission rates. A less intrusive device was made in the 70s called the Kendrick extrication device to assist in extricating race car drivers. And once people began questioning long spine boards, the KED devices began to be more widely accepted and added onto ambulances in the 80s. And in 2013, the National Association of EMS Physicians called for decreased use of spine boards, and less invasive techniques were recommended. For example, using spine boards and C-collars for extrication purposes, but quickly removing it and using an ambulance stretcher for spinal motion restriction. This recommended approach was to maintain a patient's anatomical position and minimize motion. However, the association still allowed local EMS medical directors to determine their protocol based on the best literature available. Today, you will see many providers use the KED device or spine boards for extrication, but removed for transport to hospital. Another life-changing device that's been added in EMS are powered stretchers. Everyone in this class knows how heavy stretchers are. Add an average weight person on that, we're easily talking about lifting and moving 200 to 300 pounds. And unfortunately, a lot of people we deal with aren't within that average weight range to begin with. Unfortunately, many on-the-job injuries occurred at improper lifting or lifting things that exceed our body's natural limits. And as EMS personnel, we're put in these situations constantly. The ongoing implementation of powered stretchers has helped keep us safe and patients safe. One argument made by EMS administrations is the cost of powered stretchers. The cost of a Stryker powered stretcher and auto-load mount ranges around $40,000 each. However, imagine the yearly cost of on-the-job injuries for EMS employers. According to the University of Waterloo in Ontario, Canada, a study performed on manual stretchers and powered stretchers has shown that powered stretchers can reduce on-the-job injuries in EMS by 78%. And the cost of powered stretchers and mounts is a long-term investment that will pay itself off by reducing employee and patient injuries from manual stretchers. The first known stretcher-like device documented was in the 14th century and described as a wicker frame used as a stretcher-like bed. We don't know if this device was used for medical purposes, but it is the first stretcher-like device documented. And then in the 18th and 19th century, stretchers without wheels were used for military and mountain rescues. And in 1910, Joseph Baumgartner pioneered the four-swivel wheeled stretcher that included an adjustable backrest and drop foot. This became widely popular, and even in today, you can see similar designs in modern stretchers. And the first hydraulic ambulance cot was created in 1998 by the company called Furno in England. The stretcher would be raised by a hydraulic foot pump. In 2005, Furno introduced the first battery-powered stretcher, which could raise or lower up to 700 pounds. And this became a big help for EMS because a lot of patients we deal with can be morbidly obese. An auto-load mount was subsequently added with the powered stretcher, by the way, and these became rapidly popular, but cost has always been a concern for EMS, especially in the more rural areas. Even today, EMS services are still working towards having auto-load stretchers on all of the ambulances. This luxury is an attractive feature for EMS providers looking for employment. And by minimizing the risk of significant injury during patient handling, this device vastly improves provider and patient safety. So now that we've covered some of our basics, let's talk about fluid resuscitation with patients in hemorrhagic shock. The use of blood products for hemorrhagic shock has been common for many years. For example, in World War II, the Allied forces used freeze-dried plasma on the battlefield and then would give whole blood once the patient was in the hospital setting. Once the concern for infectious disease transmission came into the spotlight, the medical field decided to lean towards crystalloid fluids and colloid fluids. It was quickly realized that flooding a bleeding body with fluids caused dilution of coagulating blood, damaged endotheliums, and alkalosis. And then in the Iraq and Afghanistan wars, these wars instigated the research into thawed plasma administration in pre-hospital settings, and it's constantly ongoing. So in 2018, the PAMPER trial reaffirmed the reduction of mortality risk compared to the standard fluid resuscitation methods. There was a subsequent trial called the COMBAT trial that assessed plasma transfusions in trauma patients during rapid ground transport to urban level 1 trauma centers. This trial failed to show a survival benefit by using plasma. However, once the PAMPER and COMBAT trial were reanalyzed, it was clarified that plasma transfusion improved outcomes when transport times exceeded 20 minutes. And today, some EMS services are making the move to carry blood products, but most still follow the 20 milliliters per kilogram crystalloid fluid protocol for adult patients in hemorrhagic shock, due to limit the negative effects of fluid resuscitation while attempting to maintain permissive hypotension. EMS employers are still considering the cost-to-benefit ratio of carrying blood products on ambulances. Some things they have to consider is expiring blood, the cost of it, the cost of equipment to keep blood refrigerated, frozen, or warm, distance to hospitals, and availability for EMS. Another lifesaver was D50 and D10. Now what brought D50 into the picture? The isolation of the hormone insulin. And then insulin was isolated in the early 1900s and became a treatment for diabetes. Now with the standard use of insulin comes the increase in hypoglycemia cases. D50 then became the standard for hypoglycemic emergencies in the pre-hospital setting for a long time. First responders have been using an IV bolus of 50 milliliters to 50% dextrose solution to treat hypoglycemia for a long time. D50 was utilized for its rapid action of raising blood glucose levels. Some research has shown that D50 can cause extravasation, which can lead to severe tissue necrosis, toxic effects of hypertonic dextrose, hyperglycemia, and rebound hypoglycemia. Because these adverse negative effects of D50 were observed, researchers decided to try a less concentrated solution of dextrose, which is where D10 enters the spotlight. Experiments comparing D50 to D10 showed that both drugs resolved people's hypoglycemic episodes. D50 resolved the issue quicker than D10. However, D50 had multiple patients experience the adverse negative effects that I just mentioned, while D10, although it took a little longer to raise the blood sugar, showed no negative effects. And because of this research, these results have made the medical field lean towards D10 as a solution to hypoglycemic emergencies. EMS services across the world are still actively transitioning protocols from D50 to D10. Now, let's talk about a common device used in emergency medicine, CPAP. Now, where did it originate? Dogs. Specifically, bulldogs, pugs, and boxers for their breathing issues. The first CPAP machine was introduced by Colin Sullivan in the 1970s for dogs, until one day a human came to Sullivan who wanted a less invasive option than a tracheostomy to help his obstructive sleep apnea. Tracheostomies used to be the standard for obstructive sleep apnea. The first CPAP was a paint compressor that had its airflow reversed and tubing attached with a face mask. This compressor made airflow pressure not consistent, which made it difficult to breathe at times. However, the person who asked to be the first human guinea pig reported feeling more aware and alert for the first time in years. It wasn't until 1990 that the first self-sealing mask, the bubble mask, was created. In the 1990s, CPAP became a non-invasive positive pressure ventilator option instead of the alternative intubation or supraglottic devices in emergency scenarios. Throughout the years, CPAP devices were modernized to have more control over the amount of pressure used and the amount of O2 used. CPAP used to require a specific machine that you had to reuse for every patient. Now we have disposable masks and tubing that connect directly to the O2 tanks without requiring a specific box machine for it. Some CPAP devices in EMS also now have the option to add a nebulized treatment while simultaneously applying CPAP. New devices also offer the option for CPAP to be changed to BiPAP without having to change to a new device or machine. And CPAP and EMS became a life-saving device for patients suffering from exacerbated CHF, COPD, pulmonary edema, and other severe respiratory issues. So the last thing I want to speak about today is capnography. Capnography is still actively becoming more popular every day in the pre-hospital setting, but where did it come from? In 1905, John Scott Haldane created a CO2 analyzer based on the principle of gas absorption. Soon after, the photoacoustic effect, which is used sound to determine gas partial pressure, further paved the way for CO2 measurement techniques. A significant leap happened in the 1930s when infrared technology for CO2 detection was created, called the Luft cell. This infrared technology was created by Carl Friedrich Luft and was initially used for submarines during the wars. And by the 1950s, capnograph monitors were used in the field of medicine, specifically in the operating rooms. People realized how useful end-tidal CO2 monitoring was during surgeries. And in 1986, the American Society of Anesthesiologists endorsed end-tidal CO2 monitoring as a standard of care when using general anesthesia or sedatives. End-tidal CO2 wasn't brought into conversation in EMS until after 2000. The American Heart Association didn't publicly recommend end-tidal CO2 monitoring until 2010. They finally advocated for end-tidal CO2 for the crucial role it played in confirming ET tube placement, assessing quality of chest compressions during CPR, and detecting ROS in CPR. Since then, the medical field has been continuously learning the numerous ways end-tidal CO2 can be used. Here are some examples we know of right now that is an important measurement tool. End-tidal tube placement confirmation, ROSC, quality of compressions in CPR, assessment of metabolic derangements, such as metabolic acidosis, lactic acidosis, and DKA. Quality of gas exchange in the lungs, the ABC status in seizure patients, quicker respiratory assessment than oxygen saturation, and less interference during excessive motion or poor peripheral perfusion compared to pulse oximeters. So in summary, all the topics I've reviewed today, as you can see, a lot of these things are pretty new and have originated from the military. And EMS is still a new growing field, and so that means a lot of our medical practices are still new and constantly being implemented today. Thank you for listening.